Hello there, my name is Finn. I'm on the forward deployed engineering team here at Medplum, and today I'm going to be talking about some of the main healthcare actors. These, in particular, include patients, providers, and payers. So these are the core actors, but obviously everyone interacts with the healthcare system here in the United States. But these are some of the entities that you might want to represent using something like Medplum or FHIR. So first, I want to talk about the patient. This is the most obvious of the three, and simply put, it's just an individual receiving care. Now, you might be familiar with FHIR, you might not. Here's the basics. We represent a patient in FHIR as a resource. So in object-oriented programming, it's the equivalent to an object. Now this would represent the base FHIR specification of a patient. There are not too many required fields, and they all tend to be quite general. I left out a lot of the examples here, but you might have a name, an ID, gender, things like that. So the example of gender is actually part of the base FHIR core patient resource. Its structure definition defines what's required, and this can be customizable. So in the United States, for example, we have the US core FHIR patient profile, and in this one, there are some additional fields. You can think of a structure definition as sort of the schema for what a patient needs. With the US core profile, it imposes an additional set of requirements for that patient resource. Next, I want to talk about the provider. So there's some ambiguity in the term provider. It can refer to a single practitioner, like a doctor, or an organization like a hospital and clinic, or even a third party, like a lab or imaging center. In FHIR, you might use a practitioner resource to represent that singular doctor, or you would use an organization resource to represent a group. Now, one thing to point out here is that the way that these FHIR resources relate to one another is through references. Different FHIR resources might have different fields that define the references. But here as an example, you might have the Shire General Hospital, which is part of the Greater Middle-earth Health Organization. For clinicians, there's different levels. A registered nurse, nurse practitioner, physician assistant, and medical doctor all have different educational requirements, and the scope of their practice is also unique. You can see how FHIR provides a nice way to universally represent these, but also give customizable qualities to different types of employees or entities of all different types. You can imagine state by state or country by country, all of these details might be different. There are different code systems and value sets that allow us to represent these different roles across different places. So let's talk about some different provider organizational structures. Sometimes it might be a solo practice with a single provider, or a physician group that brings together multiple providers under one practice. More recently, digital health and virtual clinics have gained popularity since COVID. They provide the care and manage their technology. And then there's managed service organizations. They just handle the non-clinical operations. Essentially, they provide third-party software that handles things like billing, scheduling, IT staffing, and regulatory compliance. Their contract with the healthcare providers is handled through a managed service agreement. Here, you'd see an example of how the patient might not even be aware of the MSO's role. Oftentimes, the software is white labeled for the provider. So They exist because the same set of logistical needs is often needed. MSOs can scale their software more easily than healthcare providers can scale their services. It's also a higher margin business in selling software compared to handling the day-to-day operations of a healthcare practice where labor costs are high and operational complexities can vary. So, more recently, value-based care has shifted the incentives from volume to quality. This is because of the Affordable Care Act in 2010. With this new framework, being able to track long-term patient outcomes is very important, especially if you want to be able to bill Medicare or Medicaid. This has created the market for managed service organizations to deliver high-quality, reliable software to maintain these patient histories and also be able to deliver your patient outcome metrics. With richer patient data, healthcare organizations can also understand patient risks and more effectively implement preventative care. There's other flavors of the managed service organization, such as practice-owned, MSO. So, for example, a group of anesthesiologists forming an MSO to manage their shared non-clinical aspects of their individual practices, or a hospital-affiliated MSO. So Cedars-Sinai Health System in Los Angeles operates their own MSO. Next, I want to talk about payers. Medicare, the huge federal program providing health insurance to individuals age 65 or older and certain younger individuals with disabilities, was a $944 billion program in 2022. Medicaid operates on the state and federal level, and its federal spending in 2022 was $805 billion. They offer health coverage for low-income individuals and families. Finally, private insurance companies offer health insurance to individuals and employers, and they spent $1.3 trillion in 2022. Here's how you might represent that in FHIR with a coverage resource. You can see that it references a patient and also references an organization representing the payer. Payviders are organizations that are both the payer and provider. They collect premiums, take on risk, and provide care. The classic example here is Kaiser Permanente, and they've been operating as a payvider since 1945. Why is it beneficial? Well, as part of the Affordable Care Act in 2010, insurance companies now need to spend a certain percentage of the premiums they collect. If the insurance company owns the provider, then they basically just pay to their own subsidiaries. This way, they can meet the Affordable Care Act's requirements while still keeping all of those premium dollars within their own organization. They manage the cost and quality of care, so they're incentivized to reduce unnecessary treatments, coordinate better care, and implement preventative measures. More recently, since the Affordable Care Act in 2010, other big players in the healthcare world have adopted this model. United Health Group founded its provider company, Optum, to operate in conjunction with United Healthcare. Now they operate as a payvider, fulfilling both the payer and provider role. So next I want to dig a little deeper into how resources can be linked. First example I can use is referrals. So this is the formal process between two providers where one healthcare provider, such as a primary care physician, directs a patient to another provider, oftentimes a specialist. These need to link the clinical information about the patient, like medical history, test results, reason for a referral, to the receiving provider. Before an interoperable protocol like FHIR, these interactions were just done over phone calls and faxes. So here's an example of a service request where a patient is the subject and the requesting practitioner and performing practitioner both have access to the reason coding, supporting info, links to any other resource that might be relevant. Here, the diagnostic report, for example, would contain the finding, clinical interpretation of tests, images, and so on. And that would be a separate resource altogether. So this workflow for a lab order, for example, would have a diagnostic report with an observation, maybe two. This example has two observations. Both these observations are based on the service request. This represents a field on the observation, and the result is a field on the diagnostic report. And the service request can then represent the lab order for that patient and specimen. And this is how we handle our Health Gorilla lab orders. This would be the connection with all the resources, and you can see how they all fit together. Now, another way that resources get linked to one another is a patient and provider relationship. So, on a patient resource, we would have a managing organization, and this would be the organization that stores the patient records and manages general patient communication, and also the general practitioner. And this would probably be the primary care provider. But given the FHIR spec, it can actually point to another organization, a practitioner, or even a practitioner role. Now, the term caregiver can sometimes cause confusion. You might think this is someone giving care and therefore equate it to a provider, but it's actually not a doctor. In pediatrics, a patient's caregiver is the parent or legal guardian, and in geriatrics, it's the adult that looks after an elderly parent or care aide. So, even though the related person FHIR resource exists, there's still a bunch of ways you could represent families at some clinic. For example, we've seen some people just use the contact field on a patient resource. Others use the related person resource to represent the relative and just link that to the patient. Now, say you have different family members all in one system, you would use a related person resource and link those to both of the patients. With the first patient, you would use the patient.link.other. Finally, sometimes we've seen people use the group resource and use the group members to link those to patients. Ultimately, the point is FHIR provides flexibility, and different data models within FHIR are all interoperable. They all speak the same language, but they all have different pros and cons, and they can all serve a different purpose. That's all I got for today. Thanks for watching.